Anyway, my absolute pleasure to welcome you all to Southern Eye for the education evening this evening. I'm hoping we'll get through actually 6 ages of myopia. I lied, I'm not going to talk about the dotage and death phase of myopia, so we'll leave that one. But quite a lot to cover tonight, but I'm just hoping that everyone knows about myopia already, so I'm not going to linger too long on the boring parts. And feel free, please raise your hand, ask any questions as we go. Yeah, the more the merrier, really. So the 7 ages of myopia, I don't need to tell you all about the impending tsunami of work that's going to sort of hit us all in terms of myopia. And in terms of the recent Vision 2030 statement from the New Zealand branch of RANZCO, there was a lot of things in there that they mentioned myopia in terms of getting access to atropine, access to myopia prevention control, potentially screening teenagers for myopia. So there's a lot of work that's being done at a national level, which is actually going to increase the demand of service for all of us to provide follow-up, because you can screen all these kids, but then what happens next? There's no point out identifying them, getting all the parents panicked and then saying, sorry, there's no treatments available in New Zealand, you have to go to Australia. So I know lots of people are already working in this scope within optometry, and so I guess what I'm hoping to bring to Christchurch alongside Anthony Bedgegood is that there's a lot of good backup for you in terms of getting ophthalmology reviews and making sure that we're working collaboratively together. Interestingly as well, the new Watch OS 10 comes with how much time you've had spent in daylight. So in terms of an international phenomenon, everybody's becoming more and more aware of this myopia pandemic that's coming. So some of you will be very familiar with As You Like It, William Shakespeare's play, some not so much, but this is where the 7 ages of man comes from. It's likely if you've been to a talk by Rob Weatherhead, he might have mentioned the 7 ages of man as well, because it's one of his favourite things in ocular plastics.
All the world's a stage, and all the men and women merely players. They have their exits and their entrances, and one man in his time plays many parts, his acts being 7 ages. At first the infant, mewling and puking in the nurse's arms. Then the whining schoolboy with his satchel and morning shining face, creeping like snail unwillingly to school. Then the lover, sighing like furnace with a woeful ballad made to his mistress's eyebrow. Then a soldier, full of strange oaths, bearded like the pard, jealous in honor, sudden and quick in quarrel, seeking the bubble reputation even in the cannon's mouth. And then the justice, in fair round belly with good capon lined, with eyes severe and beard of formal cut, full of wise saws and modern instances. And so he plays his part. The 6th age shifts into the lean and slippered pantaloon, with spectacles on nose and pouch on side. His youthful hose well saved, a world too wide for his shrunk shank, and his big manly voice turning again towards childish treble, pipes and whistles in his sound. Last scene of all, that ends this strange, eventful history, is second childishness and mere oblivion. Sans teeth, sans eyes, sans taste, sans everything. Sans everything.
So, Morgan Freeman did it much better than I would have if I'd quoted that book too. What are the 7 ages of myopia? So preschoolers, less than 1% have myopia, and 50% of those with myopia will have a systemic condition. So there's sort of a separate, party there if you have a preschool with myopia. The schoolboy, you're starting to see progression of myopia. The teenager, you're getting some keratoconus kicking in there, and more progression of myopia as they grow. The soldier, keen for refractive correction, don't want to wear my glasses anymore. the judge, now we're getting older, the complications of high myopia are kicking in, and then the old age with spectacles on knows it's time for cataract surgery, and what options do we consider for myopes and cataract surgery? And then dotage and death, as I said, I'm not really going to talk about that one. So myopia in infants and preschool children, so please refer those ones for a peds ophthalmology review at some point, because one rule of thumb is that if they've got more diopters of myopia than years of age, then we really need to look closely for something else going on. And we need to establish if it's axial or refractive myopia. Is this a problem in the cornea or the axial length and or the lens? And then there's a high rate of secondary myopia from prematurity, with or without ROP, genetic causes, either monogenetic anterior segment dysgenesis, myopic genes, or syndromes such as Marfan, Stickler, Noonan, Down syndrome, albinism. Usually those ones, it's pretty obvious that the children has a syndromic condition, and then glaucoma as well. So there's a high rate of ocular pathology, and in a study from the USA, up to 78% had reduced best corrected visual acuity. So even after you corrected their myopia, there's something about their eye that's not seeing well. And at up to age 10, high myopia greater than 5 diopters is unusual and worth closer inspection. And some of these kids end up having cone rod dystrophies or inner retinal dysfunction that we don't see until years later, but there's something there driving that myopic shift. And so there's quite a complex algorithm that we can follow to work up young children with myopia that we'd follow through either at the public hospital. Sometimes if I'm seeing them here, then I'd refer them into public to have electrophysiology and other testing done. And you guys don't have to go away and plan all of this, but this is what's at the back of my mind when I see these kids in an extensive workup to make sure we're not missing anything. And sometimes we need to repeat that because we see them when they're 5 or 6 and that doesn't bring up anything, and we have to wait a couple of years before their genetic conditions are starting to show up. So myopia in school children, now we're getting into axial progressive myopia, so considering glasses and potentially contact lenses. And we're aiming for their best vision. Basically now we know there's no role for undercorrection, so we want to best correct their myopia. We're getting into lifestyle advice. I think it's good for all children to be told the lifestyle advice that we give our myopes. Maybe addressing some risk factors, identifying their parents have high myopia, Asian heritage, sort of saying to the parents, look, your child doesn't have myopia, but they're at risk. And then considering when we kick into initial myopia management. So if they're increasing myopia more than half a diopter per year, and their axial length's increasing by more than 0.2 millimeters per year. And at the early stages, certainly, progression is best assessed by monitoring the axial length. And so that's where I can come in and help you guys potentially. Myopia control, it's really important to have parental buy-in. So often the kids, obviously if it was my boy Elliot, you'd be referring him to see me, but older children, you start the conversation, yep, your child's myopic, have you heard about myopia prevention, myopia control? Don't overpromise on the treatments. Their child is likely to be myopic for their whole life, but we're going to try and stop them getting to extreme levels of myopia. Highlighting that there's risks of myopic degeneration and glaucoma if we don't keep their axial length within a kind of range of normal, and then starting to address some of the barriers and concerns to treatment. Because this is a long-term treatment plan. You don't need to, sort of terrify them on their first visit when their child's minus half, and tell them that their child's going to end up with bilateral retinal detachments and glaucoma. So there's a lot of work being done and a lot of free resources online. So have many of you seen this myopia profile? So lots of good information for parents on there as well. And September every year is Myopia Action Month. So they had some really good free online courses and video workshops and information, things like that. So I was really impressed by their website. And then RANZCO's also produced something, what is myopia? Is it curable? How do I stop my child getting it? The ideas of slip, slop, slap, and slide. And then what RANZCO's recommending. And again, RANZCO at an Australasian level is pushing that we should be screening children for myopia and we should be treating and trying to prevent progressive myopia. So how do we do that? So it always involves best refractive correction and lifestyle advice, and particularly younger teens should be having a 6-monthly checkup so we can get a gist of how quickly their myopia is progressing. So in terms of collaborative care, I guess the questions really are, I know some of you in the audience are already very involved in myopia control, and some of you are prescribing atropine, specialised contact lenses or spectacle lenses. So could we just see a show of hands who's really involved with that? 1, 2, so yeah, probably at least half of you. And then imagine the other half of you working in practices where you have access to that. Yeah, perfect. So it's sort of in my little bit of market research around Christchurch, my plan at the moment, at least, is to have just once a month a myopia clinic to catch all like the parents who we're seeing anyway, and they want their children reviewed for myopia, or they've got an insurance policy that covers them for a specialist review, but not necessarily optometry care, so we can get in. And then thirdly, to see anyone who you guys might be a little bit concerned about that there's something unusual going on and you want to get them in for a review. So I'm going to talk a little bit more about our myopia clinic that we're setting up as well. So lifestyle advice for everyone, outside light exposure, basically the evidence on multiple studies now is very clear. And I recommend to all kids that they should be getting 2 hours of natural light a day. If it's wintertime and they need to be sitting by a big window, that's fine. Also, when they're outside, they should still have hat and sunglasses on, because it doesn't seem to matter if you're blocking the harmful UV rays which cause damage. They're still getting so much more lux, so much more light energy into their eyes than they would from internal lights. And then the other thing I'll tell more the older children, if they've got a choice in the classroom where they sit, try and sit by the windows, not in the middle of the dingy, dark school classroom. And as they get older, the more and more I try and push them to take more responsibility for themselves, that they need to be there trying to protect their eyes for the future as well. So yeah, interestingly, there's a dose response that more than 120 minutes of daily outdoor light exposure reduces your myopia incidence and reduces your axial elongation, but also spending less than 40 minutes is associated with more rapid and axial length progression. So yeah, really encouraging parents to get their kids outside, or at least close to natural light. In terms of optimal management, I think this is really interesting, and I feel like I've had quite a steep learning curve over the 12 months, so I've probably just caught up to where some of you are. And there's so much research coming out of this on different lens technologies. Sometimes it feels a little bit confusing and overwhelming. But one of the nice things, I think, is that there are different options. And so depending on whether a child's going to wear contact lenses or not, you can offer them that or not. They might prefer to be in glasses. Depending on what they can fund, there's different options. So atropine seemed to be very effective, but the rebound effect is noted if eye drops are ceased too early. So there's always this difficult question of when to stop, how to stop. Do you wean it down, see if they grow, then start it back for another 2 years if they do progress off atropine? And interestingly, no rebound effects been seen with peripheral defocus spectacles or contact lenses. So I think just the takeaway is that the choices of control can be modified for the family, for the child, and for their stage of myopia. So our myopia control clinic, so basically I'm hoping to work as collaborative care with you by seeing 7 or 8 children a month. I'm not planning on tackling the myopia epidemic on my own. And our plan is going to be basically starting kids on atropine in some form of lens correction, which I'll discuss with the parents. We're going to be able to offer MySight contact lens fitting in-house, but our plan would be just to give them the first month and then refer them out to a community provider who's closer and easier for them to access. And I'm not planning on dispensing glasses to anyone, so again, we'll be referring them to somebody close to home that wants to see them for that. And so then the question will be whether I see them every 6 months or whether I see them once a year and you see them once a year. You know, we can tailor that again to the situation with the family. And just to point out that any children with contact lenses or ortho case should have a pair of glasses in case their contact lenses, if they get a contact lens infection or something, that they can switch into their glasses as a backup. So yeah, I'd be really keen, and I'm working with Somia, who's at the back there. She's our optometrist here. I think, do all of you know her? I'm not sure. But Somia is going to be helping me in that clinic, and yeah, so our thought is just, you know, keep feedback to us. If there's something that we can do that's helpful or something we're doing that's not helpful, then let us know. And we'd quite like to have a list, if we could, of people who are offering myopia care and management. And so if you want to be on that list, let me know. And then that just makes it easier for me to say to the parents, oh, you live in Redwood, you know, here's some optoms close to you that you could go and see for follow-up. So then, some warning signs of atypical myopia. If they're rapidly progressing, just check for staphyloma or keratoconus, some of those other things if it's not quite fitting, if the astigmatism is increasing. And most of the myopia control studies only enroll children from 1 to 5 diopters of myopia. So if they've got higher myopia than that or they're heading in that direction, just warn them, we're going to try all these things because it's better to be 6 diopters myopic than 12, but actually we don't have as much medical evidence that you're going to go through all this treatment and effort and financial strain. We sort of can't tell you what the results are going to be like. So the arguments for doing it is that there's any reduction is potentially beneficial, but on the flip side, is this just a waste of time, money and resources when the child's going to progress to high myopia anyway? Maybe they should save their money for ICLs later. But that's kind of a more futile approach. So I think for now, I'm in the arguments for treating camp, as long as you've ruled out any other pathology. So then we move on to the teenage romantic. So we've got ongoing myopia control. They might start wearing contact lenses and they might have higher visual demands, for example, for sport, so interested in what they can do. Again, don't miss keratoconus, so ask about eye rubbing, looking for allergies, if they've got astigmatism, checking, because now with, of course, cross-linking, we're really lucky we can get them in and cross-link them before they end up with a lot of astigmatism. And so, just think about that. Kids tend to develop really paracentral cones when they first start, and often it's the posterior cornea that you see elevating if you've got a pentacam before anything else, before the anterior surface changes. Just sort of keeping that in your back of your mind as well. I'm sure you all do that. And then also, don't panic if the axial length growth is associated with a growth spurt. So you might have them on atropine and contact lenses and they're going along fine, and then suddenly they increase by half diopter in 6 months and you think, oh my goodness, none of this is working, we should stop it all. But if they've actually just had a massive growth spurt and grown 4 inches in the last 6 months, then it probably didn't matter what you were doing to their eye, and maybe you saved them from increasing by a diopter and a half in that time. So I think that's just one thing to keep as well, you can ask the parents about. And then again, as they're getting older, just reminding them again that this is their responsibility, that it's their eyes, it's the health of their eyes forever. So asking them about screen time, reminding them about outdoor time. The parents probably nag at them all the time. And then if you sit there as their eye doctor and tell them, you need to be near natural light, you need to sit next to the window in the classroom, it's amazing how much sort of mana we have. And when we say that to a 12-year-old, it means more than when their mother's telling them to do this thing at school. And the other thing is not forgetting that at 12, 13, 14, the kids might have a different opinion about wearing contact lenses than their parents. And so, just revisiting that carefully over the time as well. So the soldier, I meant to bring a chocolate and I totally forgot. So you can't have a chocolate, but does anyone know the nickname for these glasses? The acronym is BCGs, so what the American soldiers call them. This is why my husband had LASIK at 19, which he is now back in glasses, but he didn't mind because he didn't have to wear these birth control glasses. So now they actually have new glasses, so the US soldiers do not have to wear these horrible birth control glasses, but it used to put people off joining the army because you couldn't bring your own glasses because in case they needed to be shatterproof and bomb resistant and everything else and easily replaceable, and you had to have glasses, and in basic you're not allowed to wear contact lenses, so people would just not join the army because they didn't want to wear these things. So yes, moving on to the soldier or the young professional, so they want better uncorrected vision, potentially less reliance on glasses. And so if they're not happy with their contact lenses, what options do we have? So options include LASIK, PRK, ICL for high myopes. So these lenses basically, in high myopes, there's a lot of room in the anterior chamber, so we can slip an intraocular lens between the iris and their natural lens, so they can still have their accommodative facility, but you've basically corrected their myopia with that intraocular lens. That sits there for the next 30 or 40 years until they get cataracts. Then we take the ICL lens out, take their lens out, and put one lens in the bag that corrects everything. That's the plan anyway. And you can have ICLs that are toric now, so that's quite good. And then refractive lens exchange, again, risk of retinal detachment is greater in young patients with high myopia, but they might, if they can't tolerate contact lenses, they're in the -12 script. I think now we'd probably go for ICL, but refractive lens is still an option there. Advantages of PRK, so better enhancements or regularization of irregular corneas and smaller corrections. If you don't want a flap, so that might be somebody who's got a thin cornea, they do a lot of martial arts or contact sports, and the flap is seen as the disadvantage. And if you want to treat recurrent corneal erosion syndrome, you normally use PTK, but if they also have refractive error, you can treat that with PRK at the same time, so you kind of get win-win. And then advantages of LASIK, of course, you've got a flap, so then you flap the epithelium back down, so it's more comfortable, rapid visual recovery, and reduces the wound healing response. And you've just got that slight weakness of the flap, which, again, if you're doing martial arts, you might not want. And then advantages of ICL, so it is reversible. You can go and take that ICL lens out. If there's any issues with the cornea, like dry eyes, they can't tolerate contact lenses because of dry eyes, you might not want to be doing LASIK and cutting all their corneal nerves, because then you're going to potentially give them very bad dry eye. And you get excellent visual quality. So for our high myopes, that's probably a much safer option now than doing LASIK or PRK. Oh yeah, who's not so suitable for laser surgery? So if you've got unstable refraction or corneal disease, pregnancy and breastfeeding, other problems with the health of the eye, some health issues and medications, and those who do boxing martial arts, not a good candidates for LASIK. So before we do laser refractive surgery on anyone, we'd be screening for those things. Interestingly, the unstable refraction, true, can't do laser for that, but corneal disease, some of the Australians are really pushing the boundaries in what we can do for keratoconus and pellucid marginal degeneration. So again, watch this space, but it's quite exciting that we can potentially, I was working with Michael Goggin in Adelaide, and he had a keratoconic patient. So first he regularized the cornea using PRK to get rid of the higher order aberrations in the coma, and then he was going to do toric intraocular lenses to correct the myopic astigmatism. And so patients are doing really well with that. If you just went in and put the toric lenses in, potentially all the higher order aberrations from the keratoconus mean that they still have glare and night halos, and yeah, it's not great. And then the other thing in Brisbane that they're doing is combined PRK and corneal cross-linking for young keratoconics. So treating the keratoconus with the cross-linking, stabilizing the cornea, and doing PRK to reduce that irregular astigmatism at the same time. So it's kind of an exciting space. I never thought that you could do laser on a keratoconic patient because of the risk of post-LASIK ectasia, but with combining it with cross-linking, you stabilize the cornea. So it's kind of exciting. And then the judge. So the complications of myopia. Again, if you end up with axial high myopia, it's just good being aware of this. I'm hoping that we're going to see less of this if we can treat our children younger, but the downside is that we've already got a huge aging population who are myopic, so we're going to see a lot more of this before we see less. And particularly if the government is slow in funding atropine contact lenses for rapid progressors or extra glasses. Oh, actually, one note on that. If children have a community services card and access to the Enable subsidy, they can get the higher use spectacles if they are rapid progressors and they need new glasses every 6 months. So it's just something to be aware of as well. They can get funding for other things and for an ophthalmology assessment if need be. So myopic degeneration is not a pleasant thing. Lacquer cracks, Fuchs spot, choroidal neovascularization, chorioretinal atrophy, postiostaphyloma, and 62% of myopic eyes have some degree of myopic or age-related degeneration. So there's some classification systems for pathologic myopia, which is used in research, and particularly when you're trying to reduce the progression of axial myopia. And really what we're trying to do is prevent the elongation and the stretch and the thinning on the retina. And so these sort of research categories are a way of measuring to say, you know, is reducing the axial elongation going to help? You know, and in 20 years we may find out that using atropine successfully stops the myopic progression and stop the axial elongation, but genetically whatever was driving them to become myopic still drives them to get some sort of retinal degeneration. We just don't know until we've actually got kids who we've tried to treat and prevent their axial elongation. So yeah, lovely pictures of difficult eyes, difficult to figure out actually what, very difficult to pick up if there's glaucoma. Peripheral retinal lesions, retinal detachment, pigmentary degeneration, lattice degeneration, paving stone degeneration, all names, and of course retinal detachments, kind of worst case scenario. So again, we'd be encouraging people with high myopia to have regular eye checks to just check if there's any peripheral tears or degeneration kicking in. And I think most people with high myopia are pretty good at seeing their optometrist and having their eyes checked. And just this graph kind of amazed me. So the top line is male myopes, middle line is females with high myopia. Oh, sorry, it's high myopia males, high myopia females, and then just males and females with myopia, and then the bottom is males and females with no myopia. And you can just see the dramatic increase in risk that you have with high myopia, even just compared to less than 5 diopters of myopia. I don't know what explains why males with high myopia have such a higher rate of retinal detachment, but this is their 1-year risk of retinal detachment is getting up to 2%. So 2% per annum for 10 years is 20% risk of a retinal detachment. So open-angle glaucoma, there's about 2 times the risk as the general population. It's more difficult to measure their IOP because their corneas are slightly, thinner or different shape. It's harder to assess any damage with the OCT because of their peripapillary atrophy and disc tilt. They may have visual field defects from their high myopia or their retinal degeneration. And so then even the visual fields aren't reliable. So you're kind of left going, you've got a kind of a normal pressure, kind of an abnormal but normalish OCT, and abnormal, normalish kind of visual field. Like, how do I tell you whether you should be on eye drops or not? Heavy eye syndrome usually develops in people with more than 6 diopters of myopia and the associated axial length, and this is where they end up with an esotropia, and it's because of slippage of the pulley system around the muscles of the eyes. And so a bit like sagging eye syndrome in the elderly, the superior rectus lateral rectus relationship, basically the band splits and stretches and the eye sags down and out, and so you end up with an esotropia. And they get progressive esotropia and hypotropia with limitation of abduction and elevation. And so mostly they're not aware of double vision, but occasionally they are. And there's strabismus surgeons who propose doing loop myopexy and medial rectus recession to try and sort of put the eye back in its normal anatomic position, really. And then cataract in the Singapore Malay eye study, 3 to 5 times risk of increase of nuclear cataracts, 30% increased risk of posterior subcapsular cataracts. I thought that was really interesting because that's a dramatic increase. The IOL formulas can be more difficult, especially if there's a posterior staphyloma. If you do one eye, then you have to do the other eye because of anisometropia. If they're younger when they get their cataracts, you've lost any accommodation that they had left. But also, if you're used to being myopic and taking your glasses off because you're a -6 myope to do things up close, what should your refractive target be? And one of the most unhappy Korean gentlemen I remember had been a -5 myope his whole life. I made him emmetropic. He was very, very miserable. So he wanted to be -2 probably in each eye. So since then, I've either always just done -2 if I think that the patients can't really comprehend all the complicated optics, or I have a very extensive discussion with them about what the target would be. And I'd say 9 times out of 10, they're like, oh yeah, no, I definitely want to be able to read without my glasses. And then it's really hard with all the modern lenses and premium lens technology to be like, oh, maybe I should give you distance vision, but if you're myopic, then maybe you're going to get some macular degeneration, so I probably don't want to put you in a multifocal because it's reducing your contrast sensitivity. Maybe I'll just leave you -2 in both eyes and you can wear your glasses. Yeah, certainly, it's an evolving area. It's really interesting to me in terms of trying to pick what's going to make people happy. Yeah, and the other thing I hadn't fully appreciated is the magnification that people get when they take their glasses off if you're a -5 myope, make them emmetropic, and the world's not as big as it used to be. So yeah, that's kind of interesting for people to get their head around as well. And then just generally, there's higher rates of complications during the surgery. So and this I just put in because it happened about the week that I was making this talk. And basically they came out at a national level and said we're going to reduce the CPAC score to 46 across the country. But of course we've had no extra increase in resource or ability to fix this problem. So everyone's now gone very quiet about how we're actually going to fix that. Now we've got to change the government. I'm not sure whether this is now going to be a lofty goal. But actually this came from RANZCO. So New Zealand branch of RANZCO said this should be equal across the country. So ideally that's what we're working towards, and trying to figure out how we can deliver that level of healthcare to everyone. But the problem is that while we're focused on that, there's going to be how do we get focused back on preventing myopia, getting funding for atropine, and getting funding for glasses and contact lenses, when clearly the political drive is to treat people's cataracts. So again, it's another area that RANZCO's working on, and I just hope that we can really keep the focus as well on our preventative strategies of myopia and not get distracted by that. So in terms of our dotage, I thought this was a lovely quote. Someday you'll be old enough to start reading fairy tales again. And I think this is probably what most people want towards the end of their life, is to be able to read fairy tales to their grandchildren. And just that, actually my grandma with her glasses on is quite happy. So we don't have to cure everyone with their glasses, but certainly just having good quality vision for your whole life is probably the most important thing for our patients. So yeah. And then I wanted to talk a little bit about my plan for our myopia pathway here at Southern Eye, partly because I'd love any feedback that you guys can provide. But our thought is that we'll have a clinic where patients come in, they get their full ophthalmologic assessment, we'll measure their refractive error, potentially fit them with MySight contact lenses if that seems to be an appropriate thing, and start their atropine. My plan for atropine is just to get the compounded drops through Optimus. So it's going to cost the patients between $120 and $180 a month to get the compounded eye drops, which may be not possible for some families. There's a chap in Ireland now who, once the kids are in multifocal contact lenses, you can give them 1% atropine because they've got the near focus in their contact lenses. So he does atropine 1% on Friday nights. They manage with the dilated pupils over the weekend, and by the time they're going to school on Monday, most of the effect of the atropine's worn off, and they're in their MySight contact lenses and they can focus for near.
The sun doesn't shine as much in Ireland.
Yeah, exactly. And I mean, this guy basically said that the kids that complained were kids who played sport on Saturday morning. I was like, well, that is probably most New Zealand kids, I don't know. So I haven't tried that for anyone yet, but it would be a very cost-effective strategy if it worked, because basically 1% atropine is free. And then I guess it is looking at in the context of the package of paying for glasses and contact lenses and atropine. And so some families might be choosing one or the other rather than multiple strategies.
Is the compounded atropine covered under private health insurance if your children are covered?
No, it's a good question. Has anyone come across that? I haven't found anyone.
I just wondered because I thought, if you're seeing them here, and probably a large percentage of those would be covered under their
parents' insurance. Yeah, exactly. Yeah.
Or not the compounded, because that's going to be cost prohibitive.
Yeah, that's the problem. Yeah. I think that some policies do cover medications. Some policies specifically cover non-pharmac funded medications, and that's like a premium top-up that some families choose to have, so it may well be. Yeah.
I was under the impression that was over a 3-month period, because usually when I'm getting plans for 3 months.
Sorry, 180 for 3 months.
It is for 3 months.
Yeah, and so the way we'd organise that with families is basically just to email the repeats up to Optimus and have them sent out to their families. Yeah.
Is there any news on anything coming that is over the counter?
No.
Its risk profile is so low.
Exactly, yeah. And it's almost the problem of like atropine being so cheap that the drug companies, I think part of it is that there's been a lot of discussion about whether it's 0.1, 0.2, 0.5, and the process of getting something approved through MedSafe means that you'd pick one concentration and go for it, and they sort of didn't want to back 0.1 and then discover that wasn't effective and then have to go through the whole process again. I think in Asia now and in Australia now there's a off-the-shelf, packet version of atropine that you can buy, that on prescription. But that would need to be approved through MedSafe to have it accessed in New Zealand, which is where RANZCO can put some political pressure to make it happen faster, as long as they're not getting distracted by, time constrained by dealing with the cataracts issue. Yeah.
It's very challenging, isn't it, with the cost of specialty spectacles or okay or...
Exactly, yeah. Exactly, yeah. And so the question would be, do we start you on one thing and then if it's working, we don't need to add in the atropine or the other thing. If you can get away with monofocal, full correction glasses and then add in the atropine, or, maybe that's a good start, yeah. It's certainly difficult, yeah. And I think one thing I'm hoping to do is just be upfront to the parents, like this is what it costs at the moment and we'd love there to be more funding, but there isn't. But for all these reasons and this lifetime risk of high myopia, if you can afford it and prioritise it, then, just unfortunately it is an expensive process, yeah. I've looked into different ways that I can access atropine and I don't have the same options that Anthony does. So another option is to refer them, because Anthony sees people at Family Eye Centre for myopia. So if cost is really a problem, then that's another option. But they're changing all the rules about licensing and compounding and formulating eye drops. It's going to make it actually more difficult for us to do that. So,
He's got such a price difference.
Yeah, I'm not sure is the short answer. But yeah, I can't do what he's doing. So yeah, there's different licensing rules, but he's very happy to see people. And yeah, the other things about myopia that I'm really interested in is that there's an optometrist up in Hamilton who's doing red light therapy, and so they've had some really good results with that, but until that data comes through, basically the kids take a machine home and do the treatment at home. They rent the machine, and again I think that's for children whose myopia is not responding to other treatments. So again, we'll watch that space, and that might be another thing that we can offer. That's good. He's done amazing. Like, he's sort of been a one-man band trying to get Christchurch. One of my thoughts that would be really good is that if we could do point surveys, once every few years, and it might be just using, the dispensing of myopic prescription to 10 to 12-year-olds, or choose an age group, so that we can see, is Christchurch doing well in terms of keeping our levels of myopes within a reasonable number, working again with the idea of working collaboratively, like at a community level. How are we doing? We're not leaving people behind because the cost is up here, and actually 80% of the population or 90% of the population is saying, well, it's too bad, sorry, that's, Yeah. And what we're going to do here is keep the records on cataracts, because we're moving more and more to using cataracts for our cataract patients, but actually cataracts has a sort of an electronic medical record function. And so in time, as more people start using cataracts, my thought is that these kids who are going to be long-term patients, if their axial lengths and their refraction's been in cataracts for a number of years, that actually makes it accessible over the years to come, and monitoring their axial length and stuff. So it'll be kind of exciting if that works out. And certainly talking to James McKelvey, he's trying to build cataracts into a much bigger program than just using it for cataract surgery. So I think that could be a huge amount of AI data in cataracts. And so again, you can put in SNOMED codes, you can put in interventions, you could really sort of try and have a look, and maybe that would be helpful in terms of working out what works for Māori and Pacifica children, what works for Caucasian children in Christchurch, where we don't have as much UV light as in Auckland. The AI power of cataracts is quite immense. So I'd quite like to plug our data into that to try and gather more data over the years that come. Yeah, so thank you all for listening, and please keep open the dialogue. I'd be quite keen sometime next year to have a little myopia symposium for those of us who are working in the field and who are interested, and just to keep open and see what we can do for general wider Christchurch to make sure that we're all managing this condition well together, because there's going to be a lot of work for all of us. Yeah. Cool, that's all from me. Thank you.